Why? What's the primary symptom of gonorrhea? Painful discharge. The men associated that with ejaculation. So they were looking for those women and they would tell each other, hey, if you go to this one, you ejaculate for a long period of time. See, that makes no sense to us as medics. But see, that's the truth. And that's what research is. You see, that's completely different from opening the book and saying, I will memorize gonorrhea. It is that this. I can draw it off the top of my head. So you get the point about research. You're just going to find out something. You don't have to know everything. But if you don't understand one thing, you look and it's just a simple step, one step at a time. So if your topic doesn't sound interesting, imagine it's okay. What is going to be interesting about it? You just need to keep on moving slowly and don't be lazy. As she said, work is work. I mean, you've all reached here. So I think that was one thing to add. Thank you.
Yeah, this is a very interesting panel. They're answering my questions before I even ask them. I had a question to Dr. Jackie about how to remain relevant because you supervise so many students, but you've already answered that. And also but I want to push back a little bit on the publishing bit because I feel, I don't know, I want to push back a little bit because let me just give an experience because in our class, publishing is this prestigious thing. And we really want to publish. Like personally, let me just say, I want to make sure by the time I finish 6th year, I have, I have a paper in my CV. So I want to push back a little bit, and probably the people in the audience who are really also asking themselves this question. Maybe you clarify. Is it really important to publish? And this is a question I'm asking. Dr. Mburugu. Is it really important to publish?
Thank you. I've published quite a lot. So if you ask me if it is important to publish, I'd say yes. But let me tell you one thing. Publishing is important, and the reason why you need to publish is to disseminate your work. But there are many other forums that where you can disseminate, like even what we are doing here today. People will present their manuscripts here. They are still what? They are still disseminating. But the hallmark of doing research is basically disseminating your work in a peer-reviewed journal, if you are able to. But publishing is not difficult. And the reason why people are not able to publish is because they want to publish alone. So don't tie yourself. I have published almost 30 papers now, but I've not published alone. Actually, majority of them we published with other people. There's a lead, someone who was a lead person to publish. But with the networking that you have with your researchers, then you're able to move and publish faster. But as we are saying, publishing is a long process. Again, you don't want to wake up today and you want to publish in Nature. The students that we did our first group of Happy, Penina, Morina, and group, they published in the East African Medical Journal. It did not take long, and by the time they graduated, they had their paper published. But they never went for these higher journals that will reject your paper. And the moment your paper is rejected, you lose hope in research. So start small. Start with, first of all, disseminating what we are doing here today. Look for a mentor who can assist you in doing a manuscript. And then you, at the end of the day, you'll publish. And the moment you publish one, then others will follow. But as I've said, don't pressure you too much. My first paper I published when I was actually as a pediatrician, so don't pressure yourself too much.
I think I was in the same part with you, Chege. We were getting into research with the hope that we will publish later on. But just as all the panelists have said, and I think I'll just echo it, when you get into research, let publishing not be your driving point, but let the curiosity drive you into research. But publishing, you will eventually publish, I think. I think once you do the papers, it will be of interest to somebody, and they want to put it somewhere as an archive, as Dr. has said. So When we get into research, my call on to you all is get into it with the curiosity and getting answers.
I think, let me clarify so I'm not misunderstood. I do agree wholeheartedly. Publishing is important. The thing is, medicine is extremely vast, and the older I get, the more I get pushed into different things. So let me clarify. Useless publishing is what I'm trying to avoid. Because from where I sit, many people just want to do anything and to just get their name out there. And if you look at the literature, from 2019 when COVID started, they had this ridiculous statistic of 60% of the publications were absolutely useless. They weren't driving anything. There was so much. If I take World Neurosurgery, our journal, for us, it's the one over there. He said Nature is the one for everybody, but World Neurosurgery is there. So they completely changed the rules and everything about publishing, and for me, that is my issue. But when speaking to people here, we miss so much that we don't get. So I do think publishing is important, but as has been alluded to, number one, publish something that you know that you're interested in. If you want to enter academia, etc., when I was in undergraduate, all you needed was 16 publications to apply for a professor. Then it changed to 16 publications in your chosen field. Then now they're trying to put in your area of interest plus a PhD. So things keep changing because they realized once you're smart, there are things you're going to do to just move around it. The other thing that I need to say, which when I was told that if you finish your research, if you want to get published, let's be very clear, you will get published because it's not hard. Can you imagine, all you do is you'll get rejected. 60% of papers get rejected on the first try. That's not a big deal. Only 16% get taken for all the top journals. But here's the trick. They always tell you what to do. So the only thing stopping you is your ego. If they say your English is bad, your English is bad. Go change it. You know, exactly, get Grammarly, get this, do something. You're just being told what to do. The only thing stopping you is pride, and it can take time. My other issue that I have is, remember who you are. And when I say that, we're Kenyans. We have Eliud Kipchoge, everybody else, we have very many academicians. One thing that annoys me personally, and I'm starting to see this more and more again, why are we publishing in British Medical Journal? It makes no sense to me. I mean, why aren't you bringing up your own journals? We forget what the whole idea of archiving is. Why? To me, it still feels a little bit colonial. Why don't we have all of the journals here which are local? If somebody wants to find something about you, why don't they come to you? Do you get what I mean? It's like someone wants to come visit your house and you're like, oh, let me just go stay. I'll put my book in my friend's house. It's a bigger house. It's shinier. And that's the personal issue that I have with one-to-one publications. It's good for peer review because one cornerstone is how good are you? Let everybody else tell you you can't speak English, you can't write, you have no coherent thought. You need to go to the best people. So once in a while, that's good. But I think most of us need to also focus here on bringing up ourselves because that brings in lots of things. We're talking about, I don't know if it's one of the questions, when you talk about research into actions, which is one of the things that I'm learning now, going into the NGO world, people who deal with money and etc., it's very different from the academic world. We focus on, like she said quite rightly, people focus on useless status, and you see them very clearly. But the world is moving, and since we're now in the information age, people want people who do things. It's literally that simple. So focus on making yourself somebody who does things. It doesn't have to be fast. It just has to be done. Once you can keep doing that, then I think it will be much better. So, yes, publish.
Remember what I said, publishing a CV. Everyone looks at your CV to open for you the door, to invite you for the interview, to talk to you who you are. You're in a generation of status and social media. So when you say there, I have worked with, have you understood me? Then yes, you get noticed. You get noticed, you move on. You move on, you reach a point where people know your name before they meet you. So if that's the stepping stone you need, yes. But keep in mind what they told you, useless publishing, and let it not be your main focus. Because usually when it's your main focus, you get derailed and you'll never reach there. Have you understood me? Yeah? So you do need the publishing. The other thing I wanted to say was, publishing also requires time, and it depends. The challenges which you will always face, and that's why interest has to be your number one goal. is time. You're a medical student, the curriculum is given. Yeah? So you need to commit, you need to partner with people to help you move to that level. That's the time you call someone in the 50th year where they do not have a lot of work. You're like, see, you help me write this article well so that when I publish, we can put both our names in. That's one way you can use to get yourself published, yeah? Get one of your senior students who's already doing a research. You're in a year where you don't have much work. Help yourself do the Grammarly thing. I'm a lipam to online. Don't tell people you pay people online to help you do your English part, and then publish, as long as it is legit. But again, you need to remember, one of the challenges we have with students is shortcuts. And every time you tell them that shortcut will mess you up, they don't listen. So if you take some of those shortcuts, at times you get away with it because you're just like, you know who's interested and who's not. But if you're interested in publishing and you take one of those major shortcuts, there's nowhere you're going to. You collect your data before an ethical review form, there's nowhere you're going to. You collect your data without ethics approval, there's nowhere you're going to. You miss something in your questionnaire, you cannot publish. The data becomes useless. So you also need to remember that when you're doing it, you need to be thorough. And that's why I say you have to have the interest to do something thorough that is also publish-worthy. You've understood what I'm saying? Local content. He's talked about the local content. It is important to support your local journals or send them. There are some even you just pay and they will take your article. They'll even help you write it. So if you want to publish also, I believe every dream is valid. Shege, kama umeamka na umeamua by 2024 I will have published. All you have to go is online and look for someone who will help you. And you will get and you will publish. As to the credibility, whether it adds value to you or not, you need to understand. There are places you'll publish, he said nature. Guys will open and say, this is a joker. Don't get your name in such a journal. Have you understood me? Don't get your name in a journal where we'll be like, in Chezo too. Get your name in East African Medical Journal where definitely they actually do reject and they actually do peer review. So you know, it might appear like it's local, but it has more clout than if you apply, if you publish it in some of those Indian and Nigeria ones, which at times I spend a lot of time searching if this journal is legit when I'm trying to get my own data, when I'm trying to do a literature review, and I'm trying to see if this article is worth it. And the worst part about it is, Kwanza India, same article, different authors, different journal. I swear to you, identical articles. Baka, you're like, now this article was so good, but I can't use it because I actually do not know the genuine author. Have you understood what I'm saying? Because plagiarism, even that work of yours would be done. At the same time, if you don't publish, the Mzungu would come. You remember the Black Panther, the Black Leopard thing, whereby it was so much drama. Me, I couldn't even understand why it was drama. And people were very emotional because a Mzungu came to Kenya, took a picture of a leopard that was totally black, and went online and said, the first time no one has cited. Then Kenyans go like, dude, last year we sent you that picture. You refused to take it because you said you couldn't authenticate it. Then a Mzungu comes, takes the same picture, and then now you say you're legit. I swear me, by the time I went online to look for that Mzungu, they had pulled it down. Because previously another African had tried to send the same picture, a similar picture, the same leopard, and said, there's a totally black leopard in Africa. And these Jungus refused, we can't authenticate, they refused it. The next day, it was practically a year, it wasn't 2 years. The next year, some Zungu takes the same picture in Kenya, sent it. The Kenyans, of course, did not have it. And the Kenyans won. The Mzungu was pulled down and you can't even find that reference online anymore. So if you don't publish your work also, someone else will publish it. But do a good job first.
Yeah, thank you so much. Just to remind you guys, you're on Twitter. You can follow Jkumrek. It's at Jkumrek. You can follow me at Chegemina. And the hashtag you're using is hashtag Jkumrek Conference 2022. Time has moved really fast, and I know the panel has other engagements. So, yeah, I'll just give them to say their final word, just a word of advice to what would you tell yourself? I think this is a better question. What would you tell your 5th year, 4th year self about research if you had the chance to tell yourself that right now? And for Eldon, you could probably just take a minute and talk about the place of mentorship and how mentorship really helps in terms of like lifting young students into research.
I'll tell you, my 5th year self is what I tell all students. Try everything. Don't close your mind. Don't think medicine is the final thing. There's medical research. There are other many things. I have a few mentors. Hopefully they are here. And I always say, mentees or rather, I have quite a number of mentees. And I always say, do not fix. medicine is the first step. You might go into research, you might go into public health, you might go into cosmetics and these plastic surgery things. You can do anything. You can become a politician. Try it. This is the only time you have time, as much as you think you don't have time, to try it. Because after that, you'll be earning a living, you'll be building your career. To help you decide what you want to do in life, try it now.
Okay, sorry, I'm sure you've already seen I have this disease of talking. So I'll do two things. I'll give a lesson and then I'll say what I would tell myself. So the first thing is, I do neuro and I like reading about the brain. So I just make it fun. I don't have to read the syllabus all the time. I read about everything. And there are these things called heuristics or cognitive biases. Are you guys aware of them? They're little tricks that we use to just survive in life. A simple example is, if I turn like this, if we turn like this and everybody starts running there, what are all of we going to start doing? We'll just follow them and we'll run. That's groupthink. So it's knowing that instant reaction. A couple of you won't run and you'll want to look and see. That's called uniqueness bias. The ones who think that they're special. So I'll tell you one called survivorship bias. So that you don't look at the panel and think it's going to be like this. So survivorship bias is also known why we should study our graveyards. And this is important for you if you want to start a business or start a new skill or anything. So let's take what's cool now with the youth. Is it music? Is it football? Is it what? You know the music? What's happening? TikTok. Okay, there you go. Tell me somebody who's super popular on social media that everybody likes, that everybody would know. They don't even have to like, but they would know them. Anyone? Shout a name. Huh? Who's trending? Yeah. Who's trending? All right. Huh? Wow. You see, I'm not even on TikTok yet. Asia, I have no idea. I can't even. Okay, as we've learned in life, sometimes things don't go according to plan, but it's okay. We shall recover. All right, let's take Beyonce. Imagine you can sing. What's your name? What's your name? Huh? Sumaya. Okay, so let's imagine Sumaya can sing. And let's say she sings better than Beyonce. Like if you listen to her, you're like, okay, for real, she's better. And then let's say she looks better than Beyonce, she has more dance moves, she plays every instrument, she does everything better than Beyonce. And everybody who looks at her looks at like, hiya, you're actually so much better. What's the natural thing for her to think? If she looks at Beyonce on the TV, what is she going to think? Either to herself or outwardly, or her parents will tell her boyfriend this. What will people say? Ah, you're better than her. So she will think, anyway, if I am given those opportunities, I would be way better than her. I'm going to kill it. I'm just going to wait for my time. Now, that sounds like it's a correct way of thinking. It's completely wrong. And that's what's called survivorship bias. Beyonce is not there because of her merits. She's there because of what she has survived. And whenever you're going to start anything new or a skill or start research, the thing you should think about is, what is going to stop me? Another example that I give, a friend of mine has a very amazing banking app, etc. The product is amazing. I look at him like, wow, the world can use this. Guess where he had to stop? He had to get like, what do you call this, banking license? And how much does it cost in Kenya? 1 billion Kenya shillings for the license. That's where he's stopping. It doesn't matter how good his product is, he has to raise 1 billion. So for you in research, what is your problem? And just be honest with yourself. Is it laziness? Is it your friends? Is it there are too many shows on TV? You need to attack that first. Stop thinking about all the good things this is going to bring for you. So when you start, that's what you take. So that's one thing, that's a lesson, survivorship bias. That's one thing I would tell myself. The second one, which is so much better, which I think all of you can relate to, relax. Just relax. Imagine, no matter how everybody else is moving or talking about how smart they are, they're all faking it. So just relax and keep moving. As long as you stay focused, you're going to get what you want. That's one thing which I was told, it took me very long to believe. Just relax. The older you get, the more distractions come. So if I could tell myself, my younger self, this one, just continue. And the last one, which I'm learning more, be real with yourself. And being real is be honest and be true. Like she said something which collecting data without ethical approval, that's selfishness. Because that means you don't understand what ethics is. You don't think that human life is important. You're thinking about yourself and passing a little exam as opposed to other people's sanctity of data. So that's what I'm saying about being real. Once you start standing for something, other small things won't disturb you. And if I could tell myself that, I would be so much calmer and be relaxed. So that's what I would say. Thank you.
Good. Mine will be, at your generation, you need an extra skill. You will always need, even for us, we need an extra skill. So you're doing medicine, you're doing clinical medicine, but you need that extra skill. And it's you to decide which is this extra skill that I want to gain. Do you want to do it as research? And I want to tell you, if you want to move to research, then you need someone to mentor you. So don't do research alone. Always have a mentor that can show you. Eldon talked about finances. The moment you have a mentor, then they'll assist you bridge some of these bottlenecks. For example, if you want to do I've supported them to do some simple research, given some stipend for every day and some money to conduct their research. So make sure that every time you do research, or at your age now, you need a mentor. I also have my mentors that I still rely on today to move on in research. So my take-home message for you is have that extra skill, and 2, make sure you have someone to hold your hand as you move towards this challenging world. Thank you.
I think, Chege, the question of mentorship has been answered, right? And whatever will tell me 5 days ago, because I'm still in 50 year, like some few months ago, is get help. You cannot start alone. Mentorship is key. And one thing I think has not been talked about is, in mentorship still, it's peer mentorship. Me and Chege here and some other senior students, Chege and I, well noted. Thank you so much, Daktari. Chege and I and some other students here have gotten into research and have gotten the taste and feel of research. To second years, preclinical years who really want to get into research, you can tag along. Come and talk to us. We will definitely show you the way. Just recently, a first year approached me and told me that they really want to get into research. And I told them, you know what, we can help you. Come into the research club. Get the students, senior students, they'll teach you on how to come up with a topic, because by now we are well endowed with knowledge. Not enough, but it's enough to teach somebody and get them started. So mentorship is key, mentorship is imperative, and you cannot do it alone. You need somebody to hold your hand. And all other things that will be a problem to you will get solutions. Finances, I was just talking about finances. We have good ideas that we need to actualize. We need to do research. The things are finances. Dr. Murugu came in, got us an avenue for us to get finances to do research. You see, so with mentorship, everything becomes easier. So I think that's all I can say. Thank you.
Thank you so much to my panel. I want to ask Liz to come and gift my panel. We have something small for you guys. And Liz will gift you guys, and then we can release it because you people are busy. So I'll give our session chair to gift.
We have a little token of appreciation for taking your time to come and talk to us. And yeah, thank you very much.
just a minute before we wind up, Dr. Jackie is reminding me something important we've forgotten. Probably you guys have a question, but we have to release Dr. Jackie because she has another engagement. So I don't know if you guys have a question. While they're taking some nice Instagram photos, please make sure they're nice for Instagram. You guys can ask questions. So if anybody has a question to our panel, any question? Yeah, but Dr. Jackie apologizes. You can first gift Dr. Jackie, and then while people are thinking about their questions. Thank you so much, Dr. Jackie. Okay, so this is the time. If you have a question before we gift the rest of our panelists, is there a question? Maybe probably you can go around with the microphone and. Oh yeah, there's another microphone. So yeah, Lewis could take the microphone, and if anybody has a question, they could ask.
Well, thank you very much for the wonderful presentation and thanks to our panelists and the organizers.
Actually, you already answered the question for me. Whenever a student comes to me with research, and they always ask me for a topic, the first 5-10 minutes of discussion is, what do you like? Because it's something you're going to read about a lot. So I personally find if it's more personal to them, the less they are to stop or get overwhelmed. Or if they find it exciting, like me, you've heard me talk about the brain is exciting. I'm going to read about it. If it's the uterus, we're going to die.
Thank you. Frederick, thank you for that question. In research, you have to develop an interest. And all researchers that you'll see in the world, they have an interest in something. Like my interest is HIV and TB. If you pull me, like the other day I was caught by some donors and they wanted to do something in the cervix. I told me I have no interest in the cervix. So so you need to develop an interest in something. And if you wake me up at night and tell me to give a talk on HIV, something on TB, I'm able to relate with what I do every day. And even your profile, if you apply for a grant, if today you are studying the cervix, today you went to Dr. Magoa's brain, tomorrow you are studying nails, they will not fund you. So you need to develop that interest in one area. And there are several lines of funding that you can get depending on your interest.
I think work becomes easier when you do what you want to do, when you do what you're interested in. Yeah, thank you.
Thank you. Is there any other question? Okay. Yeah, there's a question here. Lewis. Is Lewis?
I'm Jaredono. I'm from Mount Kenya University. I'm really grateful for the time you've taken to share very insightful ideas with us. I have two questions. So one is, so when you're trying to collaborate with other people, yeah, eventually, what would be the right criteria to use? Would you go for your mentor to get that advice, or you would try and look for your peers? Also, since we're talking about evidence-based medicine, from the evidence we're getting, how will you be able, in case we're doing it as an undergraduate, this duration of time, how can we manage to implement it, and what are the platforms we can use to get those ideas to get implemented in the field currently? It was talking about how you'd get people to collaborate with.
Oh, okay. Oh, that's a good one. Still, from the beginning, the first theme was don't overthink it. For me personally, I can tell you what I do. First is, as you said, their knowledge in the field. Number two, which is the most important, which I'm sure is going to attest, is do they actually work? It will be very clear when you work with academia, everybody has mafuta, but things never come out. So I work with people who tend to have, what's the word I'm trying to say without sounding bad? People who will finish. So that's what I look for, and for that, as everyone has said here, talk to different people, you'll find out. Your name is the most important thing that you have. So the more you work, the more you do, you'll be able to know who to work with. Keep it simple. I like not to have many people, but you'll keep moving with that. The second thing you asked was?
About now, you've discovered something interesting. For example, let's say that practice you discovered.
Okay, I'll be rude and then I'll become less rude at the beginning. First, like the things for research, what, why, when, how. The four things for research. Number one is, who are you? Do you know if it's important? That's the first thing. If you can prove that it's important, getting research into action has many steps and things about implementation. But as has been said, if you have a mentor, they will help you keep moving. This being said, I know many medical students who have found out very small things, even locally, and have pushed them way out more than what I ever expected. From very strange things, from how eating cassava helps with memory loss, to this, someone who's doing research on rats. It's so much that can happen beyond you. It's up to your imagination, and they don't even know. So you can't boil the ocean one step at a time. Just don't give up. That's the only thing that I would say. But if you find something and everybody says this is interesting, you'll keep going. And of course, it's already been said, publish. Once you archive it, it means your peers have already said, we agree this is important. Next is you use what you have published. That's a whole different talk in itself. It's actually a course, implementation science. So it's a good question, but this time.
Okay, let me give you a practical example of what happened to myself. And the main thing is, how do you network? And the issue of networking is very important in research. As I told you, I was supervised by Professor Bimbo and Professor Duati. When I graduated as a pediatrician, they called me when I was in Garissa to supervise some MMed students who were attached to Garissa. After that, when the students were presenting, I was told to make a presentation on my experience of supervising students in a rural facility in a nomadic population. So I prepared a presentation and presented it in one of the conferences in the University of Nairobi. And one of the people, one of the researchers from Uganda, asked me a very difficult question. And what are you doing in Garissa? I told him, I had to explain, but he was wondering, why am I in Garissa and I should be somewhere doing other things? So during that time, he approached me and told me that there's a fellowship they are starting called Afya Bora Fellowship in Global Health, and they would want to give me a chance to do that. So I was given a scholarship to do that fellowship. So during that fellowship, it had researchers from Uganda, Tanzania, Botswana, and University of Washington. And as I was doing, I did something on adolescent HIV, the treatment outcomes. And they got so interested, people from the University of Washington got interested in it. and they gave me to do a stint of 2 weeks in clinical trials in the University of Pennsylvania. Based on that thing that I did. And then they told me one day to make a presentation, a poster presentation in one of the conferences in Washington. And when I was making the presentation, one of the researchers called Carrie Faber from the University of Washington got interested with my research. And she asked me to join to write a grant, which now these people are benefiting from, called the Health Education Professional Initiative. So you see, it's a process. You start small and then move ahead as you get opportunities. The first cohort of students who did HAPPY, they'll be doing their presentations here today. They published, people got interested. One time when I was doing a research, I engaged them to do data collection for me. They did their data collection. And now I'm doing my PhD. We are working with some of them. And so they've started small and they're moving. The second cohort, they're still coming, Eldon and Chege. Now they've done their first conference. So you move stepwise as you build your networks. And in the presentations like today, maybe some of your peers who are listening might get interested in what you're doing and say, can we take it a step further? And again, as Dr. Aria said, when you publish, people will see your work and start calling you. I think the other one on implementation science has been answered by Dr. Mago.
My brother, you said something on evidence-based medicine. You've done your research. How do you ensure that it is going to be used in the future to drive different clinical decisions and policy? I don't know if I have the capacity to answer this now that I'm still young in this journey. But all I can say is that you just put in the work, then the rest will just unravel and unfold for itself. It doesn't matter who uses your research to make clinical decisions. It could be you, it could be your closest friend, it could be the people you have presented to. As long as it has had an impact at the smallest capacity, that's enough. So you just put in the work, present your work, and the rest will just unfold for itself. So, thank you.
Yeah, thank you so much for your question, Frederick. Thank you, Jared. Jared, by the way, is the president. He chairs a similar club at Mount Kenya University. So thank you, guys. I think that's all because of time. Oh yeah, there's one question. Let's hear that.
Hello, my name is Joyanne, and my question is, how small should we start? You keep on telling us start small, but what exactly is small?
Perhaps the word isn't small. The word is just start. Okay, just start. Don't feel pressure. Go through. You don't even have to read all the types of research to do in the beginning. Just be like, hey, is this important? Talk to your mentor, and then they'll walk you through. Okay? Maybe start with something simple, quantitative, next you go to something qualitative, then next you go to something higher and higher. Just start with something that you're interested in. Like our gentleman there was interested in what? Oh, he didn't say. We were not interested in the uterus, for example. You can pick anything that you want. He's interested in HIV, TB, starts there, just keeps on going. And I'm sure new questions come all the time.
Okay. Yeah, I think that Magoa said just start. And one of the things that you can do, what HAPPY is doing, and you'll see their presentation, they are quite simple topics that they are doing. Like one of them was, I'm sure Mount Kenya, you go and rotate in Thika, Level 5 hospital. And one of the questions that people ask is something called decision to delivery interval. From the time a cesarean section is prescribed until the baby is delivered, what time is taken? It looks so small, but when they did it, we got many things, and we realized the waiting time for a cesarean section at Thika Level 5 is 230 minutes. Just imagine 230 minutes, the average time for, and that question they asked and answered, actually, when we presented to the Medsup, we could not believe. But they camped in Thika level 5 for 7 days, 24 hours, just looking at what is happening to. Then another group did something very simple, readmission rate. So they realized that the babies are getting readmitted. So why are they getting readmitted? You see, it's not like investigating what I'm doing for my PhD, dyslipidemia in HIV, looking at the lipid profiles. So something very simple. And I'm telling you, those papers that they published have gotten a lot of publicity. They were simple, but they'll take them far. Thank you. Have you started small?
Yeah, I've started small. Simple. It seems simple till you do it, and the impact that it brings forth. You see, in delivery interval, who will think of doing such a thing? But look at the impact that it has brought. I'm sure from presentation in Thika level 5, I'm sure they've tried to shorten that interval. It has brought impact. People are getting better services. So start small, start simple, and you wait. It will bring impact.
Also, because if you need help to do with the brain, spinal cord, peripheral nerves, or thinking, I'm available, I'm just saying. But just don't waste my time, I won't waste your time.
Okay, sawa. We are short on time, so I don't know what to do. Yeah, sure. I'm sorry. We have to move on. You can always find Dr. Magoha right here, and Dr. Murugu is staying. He'll be here for almost the whole day. I think Dr. Magoha will leave, and Eldon, you can definitely find Eldon. So thank you so much to my panel. I'm going to ask Liz to come and gift them. Again, we are tweeting at #JCumre Conference 2022. You can follow me at Chegemina _ you can follow Dr. Magoha at M Magoha. Dr. Mburugu is at P Mburugu, and Eldon is at Eldon Boy. Sir Eldon Boy. Yes, Sir Eldon Boy. Okay, thank you. And also Jkumrek is at Jkumrek. So I'm going to let Liz gift Dr. Magoha. Yeah, so let me just move so that they don't photobomb. Yes, then Liz will award Dr. Mburugu. Thank you, and then you will gift Eldon. Thank you so much. Thank you so much to my panel. Thank you guys for being engaging in the discussion. It's a long discussion. It will take much more time to end it, but thank you so much. Thank you again, Dr. Magoha, Dr. Mburugu, and Eldon, and of course, Dr. Jackie in absentia. Thank you. I think I'll hand it back to Lewis and Domi so that they can go on. Yes, Dr. Magoha. Yeah, I know.
So that that brings an end to our first panel discussion. And once again, we would like to thank the panelists for availing themselves. So we will move on to the next bit of our program, which will be abstract presentation. We will begin with an abstract from Cedric Ambenje, a fifth-year medical student here at Jkuat. His abstract will be on the unmet needs for abortion, law reforms, and modern contraceptive uptake in Kenya, Nigeria, Ghana, and Ethiopia, a systematic review. Cedric, welcome. We can welcome him with a round of applause.
Good morning, everyone. You guys look wonderful from here. Mnapendeza. So my name is Cedric Ambenje, and I'm a year 5 medical student here at Jkuat. And last year, a few friends of mine from the countries you're seeing there are from Nigeria. That was Otobo Daniel. He's currently a medical officer. And Heaven Yasane from Ghana. She's currently a master's student at King's College London. And Enwot Sina from Ghana. She's currently a doctor. We met in 2020, early 2020, and we came up with this idea, why don't we do a research? And let's just start with a research review. So we did this research review, which is basically looking at the previously done research. So this is not an original research, but an analysis of research that other people have done, that we did to just analyze the situation of Africa with regards to abortion laws, with regards to contraceptive uptake and unsafe abortion. So, and the background of this is that data from WHO speaks of that from 2003 to 2014, the prevalence of unsafe abortion has dropped from 48% to 44% globally. And that has been attributed to change in attitude towards contraceptive uptake. It has been attributed to access to safe abortion services. And that is again globally, but when it comes to Africa, we haven't really done a great job. Because 3 out of every 4 incidents of abortion is unsafe. And that comes with a negative toll on the life of the woman, the life of the family, the society, because we know complications of abortion, cervical tears, uterine ruptures, that can cause bleeding and finally shock and even death. That predisposes them to infections, sepsis, which again can lead to death, and even long-term complications such as infertility. And as you can see from the statistics over there, that 68,000 to 70,000 deaths occur from unsafe abortions globally. And of these, 97% occur in developing countries, predominantly sub-Saharan countries in sub-Saharan Africa. And 35% of these deaths occur in sub-Saharan African countries. And therefore, this is something to just not overlook, but to critically think about it and see what we can do concerning the situation. So the objectives of our review was to demonstrate the relationship between contraceptive uptake, the incidence of unwanted pregnancies, and how abortion laws play in this, come into play, that lead now to procurement of unsafe abortion in sub-Saharan Africa. So the countries, as you've seen, it is Kenya, Nigeria, and Ghana that we analyzed for this review. And ultimately, the thing that we want you to take home is the proposals that we're going to make concerning the abortion law reforms, so that we can reduce maternal mortalities from unsafe abortion and scale up uptake of contraceptive services and family planning services. So the situation in sub-Saharan Africa currently is that about 30% of all pregnancies end in abortion. And that is because that number of women are usually in denial of their pregnancy status. That makes it about 14 million pregnancies in sub-Saharan Africa being unintended. And therefore, this is not something you just ignore and brush it off, but it's something to look at it. Look at the high incidence of teenage pregnancies. For example, in Kenya, during the 2020 lockdown and the COVID situation, the prevalence of teenage pregnancies rose precipitously. And it was a crisis nationally, as you know. And that also played out in Ghana, played out in Nigeria, played out in Ethiopia, and the rest of the world. And to top it all, we are having prohibitive or unclear laws about abortion, including our law, as you shall see. So let us just have a look at the various laws in these countries and see those loopholes that we need to strengthen. So we'll use our constitution as a reference point here. And Article 26 of our 2010 Constitution, Section 4, Bill of Rights, it says that every person has a right to life, that the life of a person begins at conception, and that a person shall not be deprived of life intentionally except to the extent authorized by this Constitution or any other written law. So when we talk about any other written law, we're talking about the Penal Code, we're talking of various Bill of Rights, we're talking of bylaws that are passed by the Parliament, or any other legal entity that is accredited to, reform laws. So that means not all policies are law, but policies can become primordial to, forming laws. That is how laws are made. The people identify a situation, they agitate and advocate for it, and then reformations are done. And when so many people, enough number of people come together and lobby and push for change of some laws. So the loophole here is that the Constitution is silent on procurement of abortion services, is silent on administration of self-administration of abortion, and silent on drugs or instruments to procure abortion. Again, it's also not clear who is these, because they're saying in the opinion of a trained health professional. It's not clear who this is. Ethiopian laws, on the other hand, I'll just summarize it. They're saying that abortion is permissible in certain circumstances. As you can see, that it is when pregnancy is a result of rape or incest, the continuation of pregnancy endangers the life of the mother or the child, the fetus has an incurable or serious deformity that is now incompatible with life extrauterine, and if pregnant woman, owing to physical or mental deficiency, is incapable of sustaining pregnancy. So termination can be performed. We can see with the Constitution of Federal Democratic Republic of Ethiopia. And Ghana, of all the countries, it is the most liberal one. Ghana says that it is permissible if it is a case of rape or incest, if the mother is mentally deranged or has mental deficiency, or if there is presence of untreated fetal abnormalities, which again is consistent to Ethiopia's, and if the pregnancy is a threat to maternal physical and well-being. And it can be carried out in a registered facility by a registered medical practitioner. And noteworthy is the fact that 2006 abortion in Ghana was decriminalized in order to relieve the burden of unsafe abortion. So Nigeria, on the other hand, that is quite restrictive, especially even in the social setting. There's a lot of religious belief, cultural beliefs that are so prohibitive, and that compounded with the law, it has resulted to about 12% contraceptive access in Nigeria, with Ethiopia having twice that, Nigeria having triple of that, and Kenya we are at 58%. And the government, the Ministry of Health is targeting that by 2030, at least 68% of women who in reproductive age can access contraceptive services. So there are several things that we want to recommend based on these findings. That we need comprehensive sexual education, which is a curriculum-based system where children of different ages are taught age-appropriate sexuality education so that they can gain the right attitude, they can get the right knowledge and skills on how to make decisions for themselves and know the various things or avenues that they're having to let out their, to vent out their concerns. Things like pregnancies resulting from rape. We've seen injustices happening where people are not, where justice is not served, especially to minors who have been impregnated. And when we implement comprehensive sex education, we believe that it's going to change this landscape and we're going to decrease the incidence of unsafe abortion, as we've seen it playing out in Europe, in the United States, and in countries like Australia. And finally, we want to advocate of modern methods of contraceptive, of pregnancy prevention. These are things like IUDs, intrauterine contraceptive devices. These are things like depot injections, so that we prevent these pregnancies and they don't end up procuring unsafe abortion, and we don't, so that we can get out of this crisis as soon as possible. And finally, which is the hallmark of this research review, is we need a reformed laws on abortion. So the laws need to clarify the things that are ambiguous. We need to do away with restrictive abortion law because they only fuel the pathology of unsafe abortion in sub-Saharan Africa, because people find ways of circumventing the law, okay? When you legalize something and people are not in line with it, they're going to find ways of circumventing it. We need to develop clear laws and guidelines on unsafe abortion care, because there's some people who cannot access these services, cannot be. A doctor sends a woman, home, and they're already having products of conception within them, and that, leads to havoc. And finally, we need to legalize unsafe abortion services and/or procurement. If we illegalize that, then no one is going to get access to that. We're going to have the healthier ways, which is contraceptive uptake and safe abortion services. So I think that's the gist of what we did with the team. And the reference is the article we published at the International Clinical Journal of Obstetrics and Gynecology early this year. And that's the reference. You can always go further and read it. Okay, it's freely available. You can download it free. Thank you. I think that's the end of my presentation.
Thank you. Thank you very much. The next abstract will be by Faith Atieno. Benjamin Maseretti on effects of drug shortages on patients attending the diabetic outpatient clinic at Mama Lucy Kibaki Hospital.
Sir, thank you so much for the opportunity. Good morning. My name is Benjamin Nyariki. I'm a sixth-year medical student in Jkuat. I was the national officer in charge of medical education and research in 2020. So during that time is when we started JKUMREC, and I served as the second chairperson. During the same time, we also started other research clubs across the medical schools in the country, like Mount Kenya University, which I'm glad that is here, University of, Egerton University, Maseno University, and other universities. So I'm so glad to see the growth that we've experienced so far. So I'm presenting a research, an abstract that of our projects that we did during our elective term, which was a research elective term under the program HAPPY, under the guidance of Dr. Murugu, our supervisors, Dr. Makworo, Dr. Joey, and Dr. Beatrice Kamau. I'm presenting on behalf of Msioka, Otiego, Otieno, and Maina. So, the topic was effects of drug shortages on patients attending the diabetic outpatient clinic at Mama Lucy Kibaki Hospital, which is our teaching hospital. So diabetic mellitus, as we know, is a chronic metabolic disorder which is characterized by hyperglycemia. It is either as a result of insulin secretion, defects in insulin secretion, insulin action, or both. The current statistics is that globally there are 537 million adults, and the number is increasing. In Africa, we have 19 million adults who have diabetes, mainly type 2 diabetes mellitus. And in Kenya, we have 821,500 adults. And of these, there are 5,300 children and adolescents who have diabetes, mainly type 1. So medicine shortage is an issue of either supply that impacts pharmacy setup or dispensation of particular drug, or has an effect on patient care whereby clinicians have to utilize alternative products. So in low and middle income countries like ours, more than 2 billion people lack adequate access to essential medicines. The causes of these drug shortages are either supply issues, demand issues, or regulatory issues. In Kenya, we have NHIF, but NHIF only covers a small percentage of patient care. The high out-of-pocket costs pushes 1 to 1.1 million individuals into poverty. And as we shall see, already in our country, we have many people who are earning very, very less income. And if we increase the out-of-pocket burden, then we are pushing them into further poverty. So Kenya struggles with inadequate access to essential medication. The condition is worse in public sector than private sector. And as I have said, NHIF only covers a small percentage. On the other hand, the retail prices of medicines in the pharmacies are very high. So the justification for our study is that diabetes mellitus requires long-term follow-up and uninterrupted access to medication and specialist care. Our findings, we hoped that they will be of importance to the government, to the hospital administration, to the donors, the researchers, and if these people make adjustments, then ultimately it will be to the patients. The research questions were, what are the glycemic levels of patients attending their diabetic outpatient clinic at MLKH? What is the incidence of complications during the drug shortages among those patients attending that clinic? And what is the financial burden of out-of-pocket costs during the drug shortages? So the main objective was to assess the effects of drug shortages on patients attending the diabetic outpatient clinic, and the specific objectives were based on the research questions, as I have mentioned. So the site of study was Mama Lucy Kibaki Hospital. It was a retrospective study which utilized both quantitative and qualitative data. The population was the non-diabetic patients, both adults and pediatrics, who attend that clinic, and we did consecutive sampling. The inclusion criteria was 1, non-diabetic patients on follow-up at the diabetic outpatient clinic, diabetic patients of all ages, both pediatrics and adults, and patients of sound mind. Of those that we did not consider were those with gestational diabetes mellitus, those with incomplete data on the Kenya Health Information System, and diabetic patients admitted for inpatient care. The sample size was calculated using the Fisher 1998 formula, and we corrected it to 44 patients because normally they see around 260 patients per month. That is the target. And according to the Ministry of Health, the prevalence in 2021 was 3.1%. That's why we had quite a low number, but it was adequate for us. The data collection was both quantitative and qualitative. The quantitative data was using the pharmacy bin, semi-structured questionnaires, data abstraction forms, and the Kenya Health Information System. The qualitative data was through in-depth interview guide, in which we interviewed the patients until we achieved saturation. And data management and analysis. Analysis was done using SPSS. Descriptive statistics was used to compute the data. Thematic analysis was used to analyze the qualitative data, and presentation was done in tables and bar graphs. Ethical considerations, we cited all those. We acknowledged those that we cited. We got ethical approval from the Jkuat Ethical Review Committee. We got permission to collect the data from MLK administration. Well, the supervisors were trained professionals, and we worked with them along the process. We accorded the participants respect. We got informed consent, and confidentiality was maintained, and we ensured security of the collected data, both hard copies and also after transcribing to soft copy. So what are the results that we obtained? One, on social demographic characteristics, we analyzed 44 respondents. We had gotten data from 57 patients, but after sorting out, we got that it only 44 who had complete data. Of these, the majority were females at 65.9%. The median age was 54 years, and majority of the patients were above 50 years. Of those who were more than 20 years, that is the ones we considered adults, they were 93.2%, which leaves around 6.8% as pediatrics. And then type 2 diabetes mellitus was at a higher incidence, which tallies with the global data. Majority are business people, and majority earn less than 15,000 shillings per month. So the first objective was to look at the level of glycemic control during the period of drug shortages. So the drugs that the patients are on are metformin, glibenclamide, gliclazide, insulin, and mixtard. And we realized that we had shortages in these drugs in the mentioned months. You can see an example, metformin 500 milligrams, which was absent in February and April 2021. And this formed the time duration in which we looked at this patient, which was between March and May 2021. However, after doing our study, we realized that it's only one patient who had an HbA1c test done, which is an accurate measure for glycemic control. So we were not able to do to assess the glycemic control during that 3-month period. And then 50% had random blood sugar more than 11.1 millimoles per liter in March, 42.9 in April, and 33.3% in May. 20% had fasting blood sugar levels more than 7.2 millimoles per liter in March, 33.3% in April, and 57.1 in May 2021. The second objective was to look at the assessment of, to do an assessment of the incidence of complications during the periods of drug shortages. So we realized that the incidences of hypoglycemia during that period was only one case. Diabetic ketoacidosis was only one case, and hyposmolar hyperglycemia syndrome was, there was no case of HHS. Then we found that 65.9% reported uncontrolled blood sugar levels during that period. The third objective was financial burden of out-of-pocket costs during that period of time. So we found that 72.7% of those patients had NHIF cover. And of these, 43% reported that the NHIF cover covered fully the costs at the facility. However, 93.2% reported that they had experienced shortages in the hospital pharmacy of those drugs. During these shortages, they were forced to outsource medications from outside pharmacies. And 86.4% reported that they had been compelled to buy these medications in 9 to 10 times. So, looking at the prices of the diabetic anti-diabetic drugs in chemists outside the facility, for example, gliclazide was 12 shillings per tablet. Glibenclamide was 4 shillings per tablet. Metformin 500 was 6 shillings per tablet. And these are the same patients who have already established chronic complications like hypertension, dyslipidemia, nephropathy, and others. On the same background, these are people who are earning less than 15,000 shillings per month. So if you subject someone to expensing on buying the diabetic drugs and also buying other drugs to control the established chronic complications like hypertension, with the amount of money that they have and the family that they have, then it is going to be a great burden for them. So we did interviews with the patients, and the major theme, after analyzing and transcribing the scripts that we got, we found that the major theme was shortage of drugs at the facility. The sub-theme was referral to outside chemists, and I quoted 2 of the patients. One said that za kwanza nilipewa kidogo, za mwezi moja baada ya hapo nilikuwa najitafutia nje. Nogluc inapatikana lakini metformin huwa haiko. Another one on financial burden to the patient. One said ninge prefer kupata dawa hapa kwa sababu uko nje wanatufinya. So our discussion is fasting blood sugar levels of less than 7 millimoles per liter for diabetic patients on pharmacological treatment is what is considered satisfactory glycemic control. However, our study found that fasting blood glucose of the respondents was more than 7.2 millimoles per liter in 20% in March, 33.3% in April, 57.1% in May 2021, which means that they do not, most of them do not have the satisfactory glycemic control. We wanted to use HbA1c to assess the glycemic control, but it's only one patient who had done that. Then non-compliance increases the risk of both acute and chronic complications, as Shahid et al. 2020 had found. Our study revealed 2 incidences of acute complications during that period, 65.9% reporting uncontrolled blood glucose and 65.9% with already established chronic complications. Some of the patients reported that they were buying medications outside the facility, which may also have reduced the number of complications that they experienced. So Paula et al. Found that 1 to 1.1 million individuals are pushed into poverty, which tallies with the UHC 2021 findings. Salari et al. Singled out that those with other chronic complications are at top of the list of those who are pushed into into further poverty. So our study revealed that 77% with less than 15,000 shillings, and they have burdens with comorbidities, and therefore they are pushed into further poverty. And the NHIF cover only covers a small percentage and does not cover in the outside chemist. So in conclusion, during the study period drug shortages at Mama Lucy Kibaki Hospital, the patients had poor glycemic control. Drug shortages contribute to complications of diabetes, but it is not the sole contributor. And lastly, in low-income settings like ours, drug shortages worsen the patient's financial burden. So our recommendations are to the government, to the pharmacy, to the hospital management, to the Pharmaceutical Society of Kenya, and further to the researchers whom we are calling upon to do further studies. Those were some of our references and our acknowledgement to God, to our supervisors, to the HAPPY program, to Dr. Mburugu, our family and friends for the support that we received. Thank you so much for listening.
So thank you, Benjamin, for your presentation. Just a word of caution to the abstract presenters. We are quite short on time. So each presenter will be presenting for 10 minutes. One of our students here, Sarah Mabera, will be showing you the time left. So Sarah will be showing you the 3-minute mark and the 1-minute mark. Please adhere to it. So for our next abstract presenter, we have Faith Atieno, who will be presenting on the perception of caregivers of children attending the pediatric respiratory clinic at Mama Lucy Kibaki Hospital on stigma surrounding asthma and the establishment of asthma peer groups. Sir, Faith, welcome.
Thank you. Okay, good morning. I'm Faith Atieno, currently in my I'm Faith Atieno, currently in my 6th year of study, doing MBCHB, and today I'll be presenting a research done in sorry, I have the flu. So I'm going to present an abstract on a research done in the pediatric respiratory clinic at Mama Lucy Kibaki Hospital. And we did a research on perception of caregivers of children attending the pediatric respiratory clinic at Mama Lucy Kibaki Hospital on stigma surrounding asthma and also their perception on the establishment of asthma peer groups. So for the background information, we know that, in the WHO data, it has stated that nearly 4 million people live with asthma in Kenya. And you find that the largest percentage of these people is the pediatric age group. And usually this pediatric age group require the support from the caregiver in order to manage their asthma. So you'll find that there is a study done by Dr. Simba that showed that there is a caregiver, deep-seated perception among this caregiver that contributes to stigma surrounding asthma, and this has caused a gap in the management of asthma, especially in this pediatric population. So our aim for this study is to establish what these deep-seated perceptions are, what drives them, what causes this deep-seated perception, and how we can help to improve the management of asthma among this pediatric population. So for the objective, our objective was to establish what drives this stigma, and also after establishing what drives this stigma, we want to know the effect it has on the outcome on treatment. And number two, we introduced the aspect of asthma peer group establishment, because through these groups we can help to curb some of this perception and also improve the treatment outcome. So I'll go to the study methodology. So we did this study, descriptive cross-sectional study. In the study population was these caregivers of the children that attend the pediatric respiratory clinic. And our inclusion criteria was obviously the caregiver of children who have been diagnosed with asthma, and they have to have attended at least 1 or 2 clinic, pediatric clinic, and also those who consented to the study. So for the data collection, this study was majorly quantitative and qualitative research that so we used questionnaires and focus group discussions to collect the data. And then for the qualitative data, we used thematic analysis, and the quantitative data we used SPSS 26 and MS Excel to run descriptive statistics. So for the ethical approval, we sought from Jkuat, the ethical committee. We sought approval also from the Mama Lucy superintendent, and also the in charge of Mama Lucy Pediatric Respiratory Clinic. So I'll go to the results. When you look at the social demographic characteristics of the people who, for the caregivers that we interviewed, the largest percentage of these caregivers were female, and they were 78.3%. They were basically aged between, the majority of them were aged between 20 and 50 years. 81.7% were married, and also I think for the education level, you can note it was a large percentage of them had only attained the primary level education and had not pursued further education from there. So when you're looking at the level of acceptance of child's asthma diagnosis amongst this caregiver, when you look at that pie chart, you'll find that a large number of these caregivers have denied the diagnosis amongst their children, and that takes 55%, and 55% is quite a large number. It's quite a large number, and this has an impact on the treatment outcome for these patients. And then the next percentage is 23%, and these are the number of caregivers who did accept the asthma diagnosis amongst their children at the time of diagnosis. And then the remaining 22% had initially not accepted the diagnosis, but there's an asthma education day that was done at Mama Lucy Kibaki, and I think this helped them accept the diagnosis amongst their children. And then now, to answer our questions, to answer the objective that we are aiming on this study, one, we are going to look at the factors that drive the deep-seated perception amongst these caregivers. So we found that there are several factors that have contributed to this perception among the caregivers, and also the treatment outcome this has on their children. For one, we found it was quite multifactorial, and it ranged from socio-cultural, socio-economic, and also healthcare-related factors, or rather healthcare givers associated factors. So you'll find that the socio-cultural factors is, in this case, one, you'll find that these people, the deep-seated perception, they had quite several myths and misconceptions about asthma. One, that is asthma itself, and also the treatment that is used. So for asthma, you'll find that most of these caregivers think that asthma is once your child has asthma, probably it's like a lifetime sentence to their children, or when they're given this asthma diagnosis, they blame themselves and think that they are the cause of this asthma amongst their children. And then we found that it was basically due to lack of community awareness. And then for the socio-economic factors, we found that these people, the caregivers, didn't want to accept this asthma diagnosis amongst their children because they believe that managing this asthma for a lifetime, or just affording buying the medication for a lifetime is going to be quite a burden on them. So it was quite hard for them to accept, especially for those. A large number have not accepted this diagnosis based on that, and some of them are actually on the way to accepting the diagnosis. But you'll find that from the pie chart that you've seen, you'll find that just a small percentage of them have accepted the diagnosis. And then, and then for the healthcare-related, healthcare-associated factors, most of them had, the only factor that they mentioned is that you'll find that the healthcare workers, when they are given the diagnosis of asthma, they don't quite explain well what this disease is to them. And then after that, when they're trying to manage the disease itself, most healthcare workers have conflicting opinions on the use of inhalers as compared to the other types of medication for managing asthma. And then lastly, from our objective, we say that we want to use asthma peer groups to help curb this deep-seated perception and also to improve the treatment outcome among these children. So we tried to see if among these caregivers, if they know about asthma peer groups. And from the bar graph that you can see, we had quite a small, around 48% of them were aware of asthma peer groups, and then around 18, the remaining percentage were not aware of asthma peer groups. And the awareness of asthma peer groups were only, you find that this percentage that were aware, they were aware because there had been an asthma education that gave them the knowledge on what. And then when you look at the second, almost 0% of these caregivers belonged. Let me just say, none of them belonged to a peer group, and 100% did. None of them belonged to a peer group. And for the willingness to join a peer group, when we asked them about joining a peer group, all of them wanted to join a peer group, and they said that this can help them to improve especially the stigma they have, or they can help them overcome this perception they have about asthma. And also it will help them improve the outcome of treatment among their children. So for the platform of this asthma peer group, we gave an option of a hybrid platform, and this hybrid comprised of the physical platform and online platform, and 52% were in support of a hybrid asthma peer group. 28% were for a physical platform, and only 20% wanted purely online platform. And then for the online, their platform of choice was 91% of them wanted WhatsApp, that especially a WhatsApp group where they can form this platform and communicate to each other once every time they needed help, especially from each other. And then 7% were for Zoom and 2% were via SMS. But this for SMS, it's because most of them didn't have smartphone for the communication. And then now, as you've noted from our study, the study size, the sample size was small. It was not quite. You'll find that the population that we are targeting is the hospital serves quite a large population, but from our sample size, it was not quite that big. And this, from this, we could not give a definitive conclusion regarding the study parameters in other diverse settings. And then also for the measure to measure the change over time for this study, this was a cross-sectional study, so it studied at one point in time. So we could not, through our change that could occur over time. And then you'll find that in this research, there was less articles, or there were less peer-reviewed articles that we could use to come up with conclusions or give adequate literature review. So this was also a limitation for us. And then now from our study, we made a conclusion that in order to improve this caregiver perception and acceptance of asthma diagnosis amongst these children, the recommendation, we need to educate the public, and with a specific emphasis on these caregivers, specifically whose children have been diagnosed with asthma. I think once the healthcare providers should give them a platform, or should plan on how to educate these caregivers and hasten their acceptance of the diagnosis. And then from the study, we noted that through establishment of these asthma peer groups, there can be an improvement in the acceptance rates among these caregivers, and also we can improve the treatment outcome. With improvement of the treatment outcome, we can reduce the morbidity and mortality among these children. That's as I end the presentation, I'd like to give acknowledgement and to the HAPPY program with a big thanks to the in charge, who is Dr. Burugu. Two, I'd like to thank our supervisors for guiding us through the development of the proposal and even doing the research itself. And lastly, I would like to I'd like to in their absentia, this research was done in a group of with a group of 5 other students, 1 pharmacy student, 2 nursing students, and another MBCHB student. So in the absentia, I would like to appreciate them, and also a big thank you to the Jkuat Club for organizing this platform.
Thank you, Faith. For the next session, I'm going to invite Chege to brief us.
Thank you so much for the abstracts that have been presented. This session is supposed to be our opening ceremony, official opening ceremony for the conference. Our chief guest, unfortunately, is held up. We had invited Dr. Patrick Amoth to come and give the keynote address. Unfortunately, he's held up because of some other engagement. As you guys know, there's a cholera outbreak, and he's in charge of that, and he's also part of the people who are being vetted to be principal secretaries. So he's held up, but Dr. Burugu will open the conference for us officially. I will give a speech, and then Dr. Burugu will open the conference for us officially, and then we'll break for a brief session of refreshments and networking. Okay, so I'm super excited to be speaking to you all during the opening ceremony of our inaugural scientific conference. The significance and historic moment that today has not passed me. This conference is a first for Jkuat, it's a first for Jkuat Medical School fraternity, and it's also a first for research clubs in Kenya. Just like our club, the idea of a scientific conference dedicated entirely to undergraduate researchers was born out of the realization that these spaces are often closed to us as undergraduate students and early career researchers. We hoped to provide a platform where young research enthusiasts would congregate together to showcase their research work and network amongst themselves. Today, you shall listen, as you have been, to amazing research work done by undergraduate students, and also be part of conversations facilitated by selected speakers on critical issues in medicine, aligned with our theme today, enriching medicine through undergraduate research. Most importantly, it is our hope that beyond participating in this conference, you shall take time to network and build your social networks, which is usually the main reason why we attend these events. I truly hope that the discussions and engagements we will have today will make you a richer person and a wholesome future career researcher. Finally,